Thanks for listening to the FU Cancer Podcast. My name is Christina Rollins. I'm a dietitian, mom, and wife to a pretty awesome cancer survivor. We said FU to cancer nearly 25 years ago and are still going strong. I'm excited to share the FU Cancer movement, where we are a community of survivors, fighters, caregivers, and advocates, connecting our shared experiences, passion, and determination to live a holistic and well-balanced life. Stay tuned, because we've got a lot to talk about. Hey everyone, welcome back to the FU Cancer Podcast. Today we're diving into a critical aspect of cancer care, nutrition for patients undergoing bone marrow transplant, also known as BMT. Proper nutrition can make a huge difference in treatment outcomes, and today we're joined by Katie Harper, a registered dietitian with over 19 years of experience working with cancer patients and 13 years specializing in BMT. Katie has spent the past 15 years at the University of Colorado Hospital as a clinical dietitian, focusing on gynecological oncology and BMT services. She was recently promoted to the nutrition support team lead, where she continues to shape patient care by developing personalized nutrition plans and advancing the use of enteral nutrition in BMT patients. She has also presented nationally and internationally on oncology nutrition, and co-authored the BMT chapter in Oncology Nutrition for Clinical Practice, second edition. Katie, thank you so much for joining us today on the FU Cancer Podcast.
Thanks for having me. I'm super excited.
So let's start with your journey. You originally focused on medical oncology. So what led you to shift your focus to gynecology and specifically to BMT services?
Yeah, it just kind of happened naturally. When I was going to school, I didn't even know I wanted to be an oncology dietitian, and it was a position open. So that's what I stuck with and loved. And then I went over to my hospital that I'm at now, and they didn't have a BMT dietitian. So they were really lacking in that area. And so that's when I was like, oh, I don't know anything about BMT, but I'll give it a whirl. And then inpatient, you cover multiple services. And so that's how I got Gyn-Onc added onto my service as well. And that's a heavy use of nutrition support, which is one of my specialties. So we do a lot of IV nutrition with those patients. So that's kind of how I got there.
So what are some key differences in the nutritional guidelines for patients with medical oncology treatment versus those undergoing BMT?
Yeah, it's really shifted over the years. So with general medical oncology, a lot of the treatment is given outpatient, which is lovely for patients. They get to be in their own home, eating their own food, not in a hospital setting, and they get, treatment every month or so, depending on their type of cancer that they have. And so that it could be a whole variety of things. Some patients with breast cancer, maybe we're working on weight maintenance and because the treatment leads to weight gain. So it can vary to, just malnourished patients who need to gain weight. So it's a whole host of, wide range of different nutrition interventions. And then BMT, they're usually at our hospital admitted, and they're admitted for 30 or more days sometimes. And they get all of their chemotherapy and radiation therapy over a couple days instead of getting over months at a time. So it's very, very high dose, very, very intense treatment that causes a lot of GI toxicity. So there's a lot of nutrition support, both IV and enteral nutrition in that population.
What are some of the most common nutritional deficiencies that you encounter in this patient population?
In BMT, it's just overall lack of ability to get in enough nutrition is kind of the biggest, just calories and protein. So we've shifted our focus at university from IV nutrition to enteral nutrition because there's a big focus on the microbiome and feeding the microbiome all the way through transplant and how it can reduce risk and improve overall survival in those patients. So that's one of the biggest things that I work with those patients is just how can we get in nutrition? Oral is our first through the mouth if we can, but a lot of times they have mouth sores or esophagitis, or they just can't eat because they have nausea or vomiting. And so we have to do feeding tubes in those patients to bypass a lot of those GI toxicities.
Mhm.
And so that's the main thing, is really just getting those calories and protein in. And then we focus a lot on vitamin D. They have a high risk of bone disease. So about 50% of patients post-transplant at 1 year have bone disease, so osteopenia or osteoporosis. So we really focus on, making sure their vitamin D is adequate, and supplementing if needed. So that's a big focus. And then we use multivitamins without iron, because they can get iron overloaded from all their transfusions. So that's another thing we'll use in that population.
So I love how you mentioned really the three different nutrition modalities. You've got your oral nutrition, enteral, and then of course parenteral or IV.
Hmm.
Excuse me. What are some of the common dietary changes that you implement really at each of those stages? So starting with the oral nutrition.
Yeah, so the first thing is we do immunocompromised diet, which used to be known as a neutropenic diet. Um, and what that really is nowadays is good food safety. So it's not very restrictive. It's just making sure someone is following good food safety, avoiding high risk foods like sushi, deli meat. But it allows fresh fruits and vegetables if they're washed. So it's gotten a lot more liberal. And then use of, concentrated calories and protein. So sources of those like protein drinks, snacks that are high calorie, high protein, and just eating small, frequent meals. And then often, if they're not able to do that and they're not meeting a majority of their nutrition needs, we want to try to prevent that malnutrition during that transplant because it can be so detrimental to them. And so, if they fail oral therapy, then that's when we start talking about enteral nutrition. And we place that early on in their transplant, before they have any sores or right if they're developing any of them. And then if we aren't able to get a tube in or they fail enteral, maybe they just don't tolerate it, too many GI side effects, then our last resort is parenteral nutrition if needed.
Well, Katie, it's really incredible to really see how much nutrition can play into their treatment success. So for
Mhm.
our listeners who want to learn more, where can they go for more support?
Yeah, so one for the general, AICR is a great, American Institute of Cancer Research is a great website. I was playing around on it today to kind of see, and they have a lot of information about survivorship and specific things that may increase your risk of certain cancers and what you can do. So a lot of prevention, really research focused. So a lot of good research behind all their recommendations. And then I would say for BMT, the Leukemia and Lymphoma Society is great for caregivers, patients, and providers. And then for dietitians, I would plug the Oncology Dietetic Practice Group through the Academy. They're very, very involved, and great resource, great network of dietitians. I've gotten so many opportunities from them. And they have both a PEACH subunit and a BMT subunit. So it's a great resource for dietitians.
Awesome. Well, Katie, thank you so much for sharing all this great information with us.
Yeah, thanks for having me.
All right. Well, listeners, sorry, I'm coughing so much. Listeners, to learn more, be sure to visit our website at fucancer.health. Until next time, I'm Christina Rollins. Thanks so much for listening.